Okay, to something quite different. This is obviously not a technology talk, but more important is about what are the best strategy in treating patients. The rate of obesity, as you are aware, in North America has increased by fourfold in the last 20 years. It is probably the worst epidemic affecting North America and now the rest of the world as far as the burden on healthcare, the diseases and the complications which are ensuing this. And this is something that, again, coming to Europe and Israel for the past 20 odd years, I see slowly creeping this part of the world as well. But in North America, it really is very obvious. This is in 1995 showing the rate of obesity among North Americans, and you can see mostly we're about 10 to 14%. Now fast forward that 10 years later, this is the creeping fatness syndrome, and you see that it's reaching 20%. Now just 4 years after that, you see how quickly that is changing. And now 4 years after that, and now frankly right now all of North America is deep purple. In fact, last year it was reported that 65% of North Americans are now overweight or obese. So normal weight is now a minority. This has put a significant burden on, as I said, North American healthcare. And I'm not going to talk about bariatric surgery, but definitely there is increasing. It is now the fastest growing branch of surgery in North America. Close to 250,000 to 300,000 surgeries a year now being performed. But, and this is, as I said, it is a global problem. While North America is ahead of the game, the rest of the world is catching very fast, unfortunately. And this is not just in developed countries, but also in developing countries. You see an increasing rate of obesity. And with that goes complications like diabetes. Now, one of the other complications that we see with obesity is gastroesophageal reflux. Almost 40% of patients with obesity, and even a higher percentage, up to 65% of patients with morbid obesity, have reflux type symptomatology, and often poorly controlled with medication, because although the heart rate is controlled, the regurgitation and the reflux component is not adequately controlled on PPIs. And many patients are seeking surgical treatment of their GERD primarily rather than their weight alone. And again, the question is, if there is weight loss you can achieve, you can improve the GERD symptoms, but the reality is that most of the dietary measures only last for a short period. They're not good at maintaining. And as you know, most of medical management of obesity in the last couple of years have been pulled from the market, so there are really not very good drugs left which can treat. So really surgery becomes the only option for this. And the problem with obesity and anti-reflux surgery is, however, is that there is now plenty of evidence to show that it is associated with a high rate of failure of your anti-reflux surgery. This is a paper we published years ago looking at the effectiveness of anti-reflux surgery in patients who are obese and morbidly obese. And we found that in that group of patients, even after successful surgery, they continue to have higher reflux scores. And as far as recurrence or failure of the surgery, we had 3 times more failure rate in patients who were obese than patients who were normal weight. This is another study was published a few years ago, again showing that the failure rate in 3 years in patients with a BMI over 30 can be almost 30%, whereas patients with less than 25 or 4% and normal weight, so sort of overweight patients, about 8%. So significant increase in failure of anti-reflux surgery, laparoscopic anti-reflux surgery with weight. And there are many factors which have been sort of suggested, but mainly increased intra-abdominal pressure. These are some are anatomic failure and some are functional failures, but definitely we see with the rise in intra-abdominal pressure an increasing burden, as well as obviously gastric distension. And people have shown that if patients do take large meals, they're more likely to basically stretch their fundoplication ramp and lead to failure rates. And these patients are certainly more prone to that. So the question is, what is the best surgical therapy for obese patients? Should their patients be offered primarily a surgery for their reflux, that is a laparoscopic fundoplication, whether you do Nissen or Nissen Rossetti or Toupet, or should they now, in today's world, undergo bariatric surgery, which treats both the reflux and potentially can treat both the reflux as well as their weight? And I think that's a question right now in North America, which is a very hot topic, and I'm sure it's going to become increasing topic in Europe and in Israel. Of course, there are many ways to treat patients with morbid obesity. The most gold standards in North America is the gastric bypass on the left, although the gastric sleeve and duodenal switch as well as lap band is also increasing in popularity in North America. This is a study which looked at the use of adjustable gastric band, which is probably the most popular bariatric surgery in Australia still today. It was very popular in Europe, but its popularity is dropping. In fact, I understand last year there were more bands removed in Europe than were actually inserted. In North America, it's been on the rise, but it's now plateauing, and I think it's keeping steady, and I think people are realizing there's a high conversion rate and revision rate with the band. This is looking at patients with reflux before banding and after banding, and basically you see banding does not improve acid reflux, and as such is not really a very good treatment for patients with reflux type symptoms and obesity. Again, looking at LES pressure, you would expect that it will work very much like the angel cheek prosthesis, but it really is not a very good reflux barrier, and it's not a recommended mode of treatment of patients with reflux type symptoms. Bypass, on the other hand, and again, those who've been doing anti-reflux surgeries for years know that in the past, subtotal gastrectomy was often the last resort in patients with multiple failed anti-reflux procedures, and we all knew that Roux-en-Y after subtotal gastrectomy was an extremely good anti-reflux. It's a very major procedure to used to have, but we know it works. So gastric bypass, in a similar way, as you can see, has a significant impact in acid reflux time. I'm sorry, this doesn't work very well. And you can see the preoperative acid post-operative pH all within the normal limits. And again, it's not necessarily, although there is loss of weight, there have been some people have suggested that it's due to weight loss alone, but I'll show you some figures. And again, this basically shows a significant improvement in number of reflux episodes, the pH time, and the percentage pH time well in the normal limits. I think this is very important. And obviously symptom index is significantly improved. So really gastric bypass is an extremely effective anti-reflux operation. And it's not because of weight loss. Here is a study by Nelson, which is published in 2005, showing that the symptoms improvement occur very early after gastric bypass surgery and is maintained. These are patients looking at 3 months and then 9 months. And again, you can see the symptoms. They basically just do the symptom score evaluation, and you can see most of these patients improve within the first 3 months. So it really is not before they really lost much weight at the early stage of their after surgery. So the effect is not related to weight loss, although weight loss does help, but it's often due to the Roux-en-Y association with this small gastric pouch, which produces less acid. They looked at medication use, and again, you can see very quickly after surgery, the amount of medication required for anti-reflux drops dramatically. Now, as you know, in North America, it's standard after bariatric surgery to keep patients on some degree of PPI for the first few weeks to prevent the early stomal ulceration which occur, and most of these patients, after the first few weeks, can stop their medication and do not require. Now, vertical banded gastroplasty, which used to be popular, no longer. And again, basically people have done studies to show, and I did this specifically because they looked at the 24-hour esophageal manometry, and again, you see in Roux-en-Y gastric bypass, there is a significant improvement in the pH after surgery, and it's maintained at 1 year. With vertical banded gastroplasty, only restrictive procedure, there may be some early improvement, but at 1 year it's worse. And in fact, this is a bad operation. It is completely stopped in North America because even though it may not allow a lot of acid reflux, people do get regurgitation, reflux, and eventually esophageal dilatation, and it's something that is really completely stopped in North America. Now, as a result of the success of bypass as an anti-reflux, one of the things you notice is that in the mid-90s we saw an increasing rise, as I showed you the previous slides, with the rise in the rate of morbid obesity in North America, rise in the bariatric surgery. And that rise in bariatric surgery was associated initially with the rise in the amount of laparoscopic anti-reflux surgery because of its low morbidity, but this is now slowly dropping the rate because of the increasing number of patients with obesity and morbid obesity who are now undergoing bypass, which is an effective anti-reflux. And many upper GI surgeons in North America who used to do a great number of anti-reflux surgery are doing increasing number of bariatric surgery for probably the same group of patients sometimes, but definitely you can see a significant change in that. The problem with laparoscopic gastric bypass and why some have been rather hesitant to push that is the belief that bypass is a more dangerous operation than fundo. And that really is a myth because it's something that most surgeons who do large number of fundos and large number of gastric bypass can tell you. Really the length of stay is very similar, it's 1 to 2 days, and really the morbidity and mortality is not that much different. This is actually a very important study which came out 2 years ago. It uses data from University Health System Consortium, which is a consortium of 101 academic centers in the United States with 175 affiliated hospitals. For a 3-year period, they looked at 27,000 patients who underwent either laparoscopic fundoplication or laparoscopic gastric bypass. Not all the gastric bypass were done for reflux, were done for a variety of reasons. These are patients who were morbidly obese. But they looked at this group of patients with morbid obesity who underwent either a fundoplication or gastric bypass. Obviously, the bypass patient had higher illness severity score. This is to be expected because even if you have a morbid obese patient, when you consider lap fundo, if you're really severely affected by severe diabetes or various other medical conditions, you may choose, say, you better stay on your PPI. But again, bypass, that's why they're undergoing surgery. So they had a higher illness severity score. Despite that, what they found was that in this group of patients, basically length of stay was very equivalent. Complication rate was actually lower in the bypass. Even though the percentage is only 3% lower, the complication, that was statistically significant because it was such a large number of patients in the group. The mortality rate was not really statistically significant, although it was just a little bit lower in laparoscopic fundo than bypass. And risk-adjusted mortality was also not statistically significant. And the cost to the system was equivalent in the hospital stay. And obviously the post-op period, the laparoscopic gastric bypass is a more cost-effective, and again, the cost utility of bypass has already been established. So really this paper sort of hopefully put close to the argument that bypass is a more dangerous option to laparoscopic fundoplication. As somebody who's done close to 3,000, and some of you may are aware of all my publication in the laparoscopic fundoplication era, I certainly in the last several years have changed and I'm doing less and less fundoplication, and I'm doing more and more gastric bypass, even for patients who present primarily with reflux type symptomatology if they're morbidly obese. So in summary, obesity is an independent cause of failure for anti-reflux surgery. Laparoscopic gastric bypass provides an excellent control of reflux as well as the weight loss, as well as other comorbidities of weight. And I think gastric band and sleeve are not really, should not be considered as an anti-reflux operation in patients with morbid obese. This is my own recommendation. I think patients who are greater than 40 BMI, frankly these days, even if they present with anti-reflux, with severe reflux, I'm suggesting that they should seriously consider laparoscopic gastric bypass. 35 to 40, I think increasingly I'm referring them again. They're offering them both, but certainly suggesting strongly that laparoscopic gastric bypass should be considered. The group which is really yet to be determined is the patients with a BMI of 30 to 35. Now, this is the group that a bypass and fundoplication both are effective, and certainly there is still not good evidence. I think if they're type 2 diabetic, I am more prone to provide gastric bypass because the gastric bypass treats both their diabetes as well as their reflux. And then obviously patients less than 30 still undergo fundoplication. So really the two groups which I'm now doing fundoplications are up to BMI of 35. Anything over that, increasingly now, I'm actually offering them gastric bypass. Right or wrong, it seems to be a better option for this group of patients. And again, I think we are now doing studies, and it's going to be a few years before I can definitively say whether this type of strategy is a more effective strategy or not. But again, I hope there are some of you who are convinced that to my arguments. Thank you very much.